The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening, and welcome to the BCIA Neurofeedback Mentoring Webinar, Benzos and Brainwaves, How Common Medications Impact Neurofeedback Treatment. We have 12 new professionals joining us today, and so a special welcome to them. Oh, I just got a note. We don't have 12. We have 21 new professionals joining us today. Wonderful. We have people joining us from Canada, the United Kingdom, India, and South Africa. So welcome to everybody. Our presenter today is Dr. Erin Conway, who graduated from the Chicago School of Professional Psychology with a doctorate in forensic psychology and a specialization in neuroscience. She recently obtained her Master's of Science in Psychopharmacology, also from the Chicago School, and is on track to becoming a prescribing medical psychologist in Illinois. Dr. Conway has her own practice, Cerebrum Neurotherapy, counseling and consulting in Lake Zurich, Illinois, where she provides neurofeedback, counseling, neuropsych testing, and neurofeedback and practice growth consultation services. She is the Director of Psychological Services for Elemental Center, a large specialty practice, and has a BCIA accredited 36-hour didactic training program that she provides. Now, this is a little bit of housekeeping notes for you. After the presentation, we will have a Q&A time. Also, Dr. Conway and I decided that we are going to have another Q&A right after she presents client number 1. So be thinking of your questions, and when you have a question about something that she said or you want more information, type your question in the question function box on the administrative panel of the GoToWebinar feature that you'll see on your screen. Now, early next week, we will be sending you an email, and it has a link to a brief evaluation using SurveyMonkey. It's a few questions, and what it does is let us know how we suited your educational needs. Did we do a good job? And what would you like to see? Do you have an idea for another webinar you want to see? Right after the evaluation questions, the next screen takes you right to the exam. There's not very many questions, usually 6 to 10. They're all multiple choice. Now, each question must be answered correctly for you to see the very next question. If your question box doesn't move, it means you need to change your answer until you get the correct answer, and then that will allow that screen to move. The very last screen in that survey is your CE certificate. The instructions indicate that you are to put your name in the box and print that screen. It's just a Control P, very, very simple. That is your CE certificate. So we're very happy to have you with us today, and it's exciting to share with all of you. So without further delay, I'm going to introduce Dr. Conway, and off we go. Thanks, Dr. Conway.
Thanks so much, Judy. And now that I have all of your attention with a picture of a very cute doggy, let's proceed. So Judy already read my introduction. There's also a picture of myself, so you can imagine what I'm sitting like in my home office. And she already read the introduction, so I don't have to go into that for you. Let's move on to what are we going to learn today, because that's very important. So I'm going to talk about just common medications and their applications. We're also going to talk about how these common medications impact brainwave functioning. You will also learn how those medications impact neurofeedback treatment. And you will also learn how to have meaningful conversations with your patients regarding medications and when to direct your patients to speak with their providers about their medications. All of that impacts neurofeedback treatment. I put this slide in there because I think it's very important for your practice, for any kind of neurofeedback, to understand what common brain waves do and what they look like on a raw QEEG before we've transferred them into digital data. So this is really just for your own knowledge or resources that you can have. So beta, SMR, alpha, theta, and delta. Okay, so what are these common medications? We're going to talk about antibiotics, we'll talk about antihistamines, and then we'll move into more of the psychotropics that we see, antidepressants, antipsychotics, benzodiazepines, and then we'll talk about marijuana, stimulants, and then I have some few honorable mentions that also alter brainwaves and are worth discussing in sort of a very brief context. You may also be wondering why I have a picture of a bunch of Pokemons. Well, my son was in the office as I was doing this because I was working from home, and he's 7.5 and basically said, "Mom, you should you should put Pokemon into your presentation." So you will see Pokemons throughout the presentation mimicking different side effects that medications give, or just various things. So that's my theme for this presentation. It's Pokemon. Okay, so antibiotics and antihistamines I'm going to run through just very briefly. I'm not going to go as in depth with them as I will some other ones, just because, again, in our society, you're going to see children, teens, adults who have seasonal allergies or who are fighting a bacterial infection. And so it's important to understand how these medications can impact neurofeedback, because they can. So antibiotics, for example, I don't know if anyone has, I'm sure many of us have taken a course of antibiotics. They can show a marked increase in the amplitude of slow waves, in particular theta. So I don't know if you've ever seen a kid on antibiotics or yourself have felt the extra tiredness that you get from the antibiotics. So it's really important to consider if you're using a theta-beta ratio intervention, which we do for attention, if we're trying to work on some ADHD, or if we're trying to uptrain alpha theta in the posterior. All of that's very important, because if they're already tired and you're uptraining theta, you may not see the kind of results that you're looking for if they're just, if they're a 2-week course of antibiotics, might be kind of rough. Also, if you're running a QEEG when they first come in and they've just finished a course of antibiotics, you may also see increased theta. So it may give you a little bit of a skewed picture. So it's important to ask if they've just finished a course of antibiotics. Okay, antihistamines, obviously, very common, maybe a little bit more common than antibiotics. Again, another marked increase in the amplitude of slow waves, particularly theta. So kind of going along what I already just said, it's very important to consider when using the theta-beta ratio, again, that if there's already an abundance of theta, you could just be sort of already training what's already there. So they might not make any progress if they're, especially on an antihistamine that's very long acting. Okay, antidepressants, these work by inhibiting the reuptake of specific neurotransmitters. And so what that does is it increases these neurotransmitter levels around the nerves within the brain. Most commonly, I'm sure we've all heard of selective serotonin reuptake inhibitors, or SSRIs, as they're very commonly called in the field. And these are antidepressants that will affect serotonin levels in the brain. There's also SNRIs, MAOIs, there's all different kinds of antidepressants, but we're not going to go into those in depth today. We're just going to talk about antidepressants as a very broad category. So conditions where antidepressants are used, depression, general anxiety disorder, the patient is presenting with agitation, got obsessive compulsive disorders, manic depressive disorders, if there's childhood enuresis, a major depressive disorder, diabetic peripheral neuropathic pain, social anxiety, and PTSD. So I am going to wager a bet that most of the people attending this webinar are working within the mental health field and it's very, very likely that you're going to see this medication in your practice if you are treating people with mental illness, which is obviously what mostly we are going to use neurofeedback for. So it's important to understand, again, ask what your patients are taking so you know how that might impact neurofeedback. So some of the common antidepressants that you might hear of are Zoloft, Celexa, Prozac, and the generic names are put into parentheses. Those are the ones that I hear, Lexapro, Cymbalta, Deseril, I don't hear, oh, Trazodone, yeah, so you hear Trazodone, you're probably gonna hear the generic more often than you'll hear the brand. And it's really important, again, to ask what they're taking so that you can document and watch how neurofeedback impacts the medication, which I'm gonna talk about next. Okay. So how do antidepressants actually affect the brain? They produce an increase in slow wave, typically theta activity. They can also decrease alpha and increase fast beta frequencies in the mid to upper 20 hertz range. Amitriptyline, for example, produces more slowing. We can see amitriptyline used in very small doses to help a person fall asleep. Tricyclics can produce generalized asynchronous slow waves and spike and wave discharges. We don't use tricyclic antidepressants that much anymore because they have a pretty deep impact on the body. And they also may increase sleep spindles. So that's antidepressants. Okay, so before I move on to the next one, which is the antipsychotics, I'm gonna sort of infuse how to monitor this. So when you've got a patient who comes to you and is telling you that they're taking antidepressants, you're obviously going to document it and sort of have it in the notes and in front of you every time you're meeting with that patient. Why it's important to document that is because neurofeedback treatment may start out great with that patient, and they may be showing improvements in overall mood, better sleep, better attention, decreased anxiety, improved depression, whatever it is, you know, you're trying to work on may improve in the initial sessions, usually about 10 sessions. And then what will happen is if the medication is impacting the brain, as we go through neurofeedback is a organic rewiring of the neurons, and neurons that wire together fire together, which decreases the need for medications. And that's why it's very important to be willing to have open conversations with your patients. Because if a person is taking a medication, whether it's a stimulant, a benzo, an antidepressant, it doesn't matter if they just started that, 6 weeks ago. It doesn't matter if they've been on medication for 10 years. Neurofeedback is going to impact the amount that the brain needs. So you're going along, neurofeedback's going great, and all of a sudden your patient comes in and says, I'm really struggling with these weird side effects, like I'm shaking, or I'm restless, or my sleep is weird, or I have trouble focusing. Usually with the antidepressants, what I hear quite often with neurofeedback is they come in and they're extremely tired. Again, antidepressants produce an increase in slow theta activity. If they're taking too much antidepressant into their bodies and then obviously impacting the brain, you're also producing theta activity, which is that wave that happens right before we fall asleep. So that's kind of my cue to say, let me go back and look at the chart and let me see, what they're taking. Oh, lo and behold, they're taking fluoxetine, 20 milligrams. And we kind of go, so when did you experience this tiredness or these changes or these weird side effects? And they'll say, oh, it's been going on for a while, but I noticed it's getting increasingly worse. Well, that's my cue to say, I think it's time to talk to your provider and see if they're willing to make a medication adjustment for you and decrease it a little bit to see if that doesn't improve your symptoms. And I'm going to go in a little bit more depth on those actual conversations, but really what you're focusing on is the emergence of side effects. So neurofeedback, if the person comes to you on medication, that's great. I can work with that. I know some neurofeedback providers will say, please stay off of, you must get off of all your medications. I don't believe in that. I think that's actually a very, very dangerous way to practice neurofeedback. I just do really extensive monitoring of any weird side effects. And I mean, I'm even saying, like, I want to know if your bowel movements change, so that is very important to me. So I'm always following up with a checklist every single time the patient comes in to make sure that A, I have a good protocol, and B, it's not time to have a conversation about medications. Okay. Antipsychotics or neuroleptics. Neuroleptic is a term that you may hear. Typically, you'll hear antipsychotics, but neuroleptic refers to the effects of an antipsychotic drug on a patient. These have pretty significant impacts on cognition and behavior. They tend to produce a state of apathy, a motivational behavior, a lack of initiative, and a limited range of emotion. In psychotic patients, they cause a reduction in confusion and agitation, and they tend to normalize psychomotor activity so that person, can get back to their life. So here's a list of some of the common antipsychotics that you may hear. Again, I tend to focus on the generic brands, which are in the parentheses, because most insurances give you the generic brand. So aripiprazole, Abilify, Safris, Latuda, I've been hearing that one a lot. Seroquel, I hear quite a bit, or quetiapine, which is the brand name. And then risperidone is also one that I hear, or Risperol. I hear that one quite often. So it's really important to understand side effects of antipsychotics. And there's my weight gain is one of the biggest side effects that you hear that becomes troublesome with antipsychotics, because that actually impacts medication compliance. So you may even have a patient who comes in and says, oh yes, I'm just was prescribed an antipsychotic, and I'm doing okay. But as the medication starts to move through their system and build up in the plasma in their blood, they may start to experience some of these very uncomfortable side effects, which leads to this medication non-compliance. And so that's another thing to be mindful with neurofeedback is you always want to be checking in and making sure that they're still taking their medication. So, patients aren't always very communicative, and so they may not tell you that, oh yeah, I was experiencing blurred vision, dry mouth, drowsiness, muscle spasms, and I decided to stop taking my medication because I didn't like it. And so the body's then going to go through withdrawal. And then that's a whole nother conversation, because now we're seeing withdrawal symptoms, which does not necessarily mean that you have a bad neurofeedback protocol. It just means that this person is going through withdrawals. You need to refer them back to their provider for a medically healthy taper. Nobody should ever stop their medications without the direction of a doctor, preferably a psychiatrist. But definitely important to have that conversation. Okay, so antipsychotics, kind of already mentioned some. We are at tardive dyskinesia, which is uncontrollable movements of the jaw, lips, and tongue. And that's actually not necessarily reversible, even if they stop the medication. So that's one we look for quite a bit when we're looking at antipsychotics. Weight gain, like I said, is a really big one. It's a big motivating factor for treatment noncompliance. Akathisia, which is uncomfortable restlessness, and constipation. So I had a patient who really struggled on antipsychotics, stopped taking them, didn't tell me, and I, was going through these, these very emotional crying fits, and I couldn't figure out why. And I finally, said, are you still taking your medication? And she said, oh no, I stopped. And that was a whole different conversation that we had to have. Okay, antipsychotics and the brain. So what do they do? They increase the coherence of the EEG. They decrease beta. And for those of you who don't know, beta produces anxiety, produces, you get into beta 2 and you're looking more at like a panic attack wave. So it decreases beta, which can also decrease anxiety, agitation, restlessness, all that stuff. They can increase temporal and frontal sharp theta transients, reduced alpha blocking with sensory stimulation, which may be correlated with the memory disturbance that can happen with these meds. So if we're not, if we've got a slow brain, if there's alpha just present all the time, it's very hard for the brain to focus. And that's why we can see memory disturbances when we have someone who's taking these meds. Obviously, there's dopamine receptor hypersensitivity because these antipsychotics do play on the dopamine receptors, which can cause the tardive dyskinesia, which was the movement disorder that I talked to you about, which when we've got this hypersensitivity, it's prolonged bursts of mixed, fast, and or sharp transients and slowing. So that's where we get sort of the movement and the twitching of the face and the lips. And then you've got a potentiation of latent epileptic form activity, which can be the uncomfortable restlessness that we see where they just can't, seem to settle down. Oh, hold on. Sorry. All right. So my benzodiazepines are backwards. Okay. So benzodiazepines are the next category of that we're looking at. So these are the benzodiazepines here. Again, this is just a list for your own reference on what you might see names to be. I'm sure many of you have heard these, so I'm not going to read them all. I'm sure you've all heard of them and in some respect. Okay, so side effects of benzos, they can cause lightheadedness, drowsiness, confusion, sedation, memory impairment, improper balance, increased or decreased in appetite, nausea, vomiting, constipation, weight gain, dry mouth, reduced libido, or fatigue. And so it's really important when we're working with benzos as neurofeedback treatment progresses, especially if you're working on, for example, an anxiety disorder. Benzodiazepines are most likely prescribed to reduce anxiety. And so what happens is if you're doing, for example, an alpha theta protocol at P3, P4, decreasing someone's anxiety, as their anxiety improves, they won't need as many benzodiazepines to manage those breakout panic attacks that they're having. So it's really important that you have a conversation. If that's a protocol that you're moving to, it's really important that you have a conversation about potential, what's going to happen if, as their anxiety stabilizes, they have to be ready and willing to let go of that benzo use, whether they're using it on a daily basis or if they're using it just for panic attacks or those highly anxious moments where they can't function. And this is where I kind of get a little bit of pushback from my patients because benzodiazepines are addictive. They do make the brain feel very good. And so when that happens, sometimes they go, oh, well, I'm so afraid that if I stop taking the benzos, my anxiety is going to come back and I just don't want to do that. And I say, okay, I understand. Then maybe neurofeedback is not the right treatment for you if you're not willing to explore letting go of the benzos. And I refer them back to their prescriber because whether it's addiction, whether it's, just genuinely a fear of, the anxiety coming back, which is very real for people, and I totally understand, there still needs to be some willingness of the patient to decrease or alter their meds in some way to accommodate the changes that happen from neurofeedback. Because again, as the brainwaves stabilize, we need less medications. Okay, so there obviously are some very serious side effects of benzodiazepines, particularly when we see long-term use of benzodiazepines, and that is respiratory depression, withdrawal symptoms if we start or if we decrease or alter the medication or stop it completely. Dependence and abuse. So as they the body continues to build up a tolerance to the medication, they're also going to need more and more of the medication to achieve the initial effect. Can cause jaundice, seizures, which there's Pikachu, and he's an electroform type, so looks like he's having a seizure to me, so that's why I put him in there. Suicide, slow heart rate, severe low blood pressure, fainting, akathisia, and then an increased heart rate as well. Okay, so what do benzos do for the brain? Well, they increase gamma aminobutyric acid, GABA. I'm sure, again, a lot of you have heard of this neurotransmitter. GABA reduces brain activity in the areas of the brain responsible for rational thought. So that's kind of why we hear of these like benzo comas or, benzo fogs that they get into where they just are kind of like, zoned out. They can still respond, but that's why we say, please don't drive on benzos or operate heavy machinery, because reaction time is decreased and ability to think rationally about things is also decreased. Emotionally, benzos affect emotionality because they decrease because they increase GABA, they also decrease anxiety. They can impact the thinking process. So, if you're, for example, I don't know if anybody I've heard this reported from a couple of my patients who have surgery and they get sort of a mix of benzodiazepines and downers. They don't remember. It sort of cuts off the ability of the brain to form long-term memories. So they remember getting the initial dose, but then nothing afterwards. So that's kind of where benzos can actually impact long-term memory formation, control of consciousness, muscle tone, memory, and coordination. And again, they have a deep effect on the brain, which is likely what alleviates problems like anxiety. So there's also a school of thought that says that's where this addictive nature comes from, because they do make this person feel better and sort of right them in terms of getting rid of their anxiety. And so the person comes to rely on them instead of learning coping skills, instead of doing neurofeedback. The person comes to rely on them to take care of their anxiety instead of doing these more long-term beneficial treatments. Okay, so marijuana. For those of you who live in Illinois, marijuana was recently legalized. Recreational marijuana was recently legalized. So I think it's very important to talk about this one. I know Judy's in Colorado, so it's legal there. So marijuana is a plant whose scientific name is Cannabis sativa. Typically, users will feel this intoxicated high, not necessarily. So now as we see these more chemically modified, or sometimes they're called medicinal strains, when they have like these high concentrations of THC, we can also see some psychosis in these high concentrated THC compounds, but also we can see an increase in anxiety. So it's kind of the opposite of what marijuana is supposed to do. So as these new strains come onto the market, we're sort of having to adapt to, okay, this isn't just like a homegrown plant. We have to sort of make ourselves aware of all these different strains and neurological effects that come with the different types of marijuana that are now on the market. So tetrahydrocannabinol, THC, that's the main compound in marijuana. It's what gives it that high intoxicating effect. It's still illegal in most jurisdictions. It's also still illegal at the federal level. So even though Illinois, for example, has said, sure, go ahead and light up that joint at a party, it's still illegal at the federal level. It's also the most commonly abused illegal substance worldwide. So we used to think that it was alcohol that was the gateway drug to, heroin or, these higher, street drugs. It's actually marijuana. Okay, so some side effects of marijuana. Asthenia, which is a lack of energy. People can get upset stomach. If you take too much, which that is a thing. A lot of people say, oh, you can't overdose on marijuana. That's absolutely false. You can absolutely overdose on marijuana. Will you die from it? It's unlikely, but your body is going to react to it as a poison, and it's going to cause these really very unpleasant side effects. I worked in substance abuse for 3 years, and I will never forget working intake when a person came in and had eaten, it was like these candies and they were edibles, and he had eaten 3 or 4 of them, and they were 50 milligrams each. And he was just vomiting, sweating, in the bathroom, dizziness, his body was clearly trying to get the drug out of his system. And he was just completely psychotic, was hearing voices, was, saying, checking in with us, making sure we were still there. So you can overdose yourself again on marijuana. So everybody thinks, oh, this is a plant, it's so safe. And it has bad side effects when taking in very high doses. It's also very bad for a developing brain. So when you see these adolescents who are, using marijuana recreationally, it can produce amotivational behavior. It can also slow down cognitions. So they, may see a disruption in their learning or their ability to focus or pay attention at school. Marijuana effects will also produce as sustained alpha on a QEEG. So you're going to see it on either a QEEG or a mini Q. If you do the mini Q, you'll see it, and it'll show up as, sustained alpha. Okay, so we kind of already talked about sleeplessness, confusion, hallucinations, and paranoia. And at that point, the drug just has to move through the body, and the side effects usually go away after that. Okay, so marijuana increases frontal alpha. When you have chronic exposure, kind of already talked about that, the amotivational behavior, you're going to see sustained alpha. You can see some withdrawal-like symptoms. Again, that's not really, we think, oh, marijuana, it's, gets out of the system once, it runs its course through your body. Well, no, THC is actually stored in the fat cells of the body. So if you work out, it can produce a tiny, tiny effect. Or if you go to take a drug test after you've just worked out, and, you burn some fat, it's likely it could show up on a drug test. We also see increased frontal interhemispheric hypocoherence and phase synchrony. We'll see effects on evoked potentials. And again, we'll see a little bit more serious side effects, such as a 2-fold increase in the incidence of schizophrenia among young people who started using in their teens. So as much as it is difficult to talk to teenagers about their drug use, I see mostly children and teens for neurofeedback. And so what I do is I let the parent come in and I say, okay, tell me what you need to say. And then I kick the parent out and I say, okay, you need to tell me anything you don't want your parent to hear, because I'm going to be able to tell, if you were smoking marijuana on the, on the new queue that I'm going to run. So it's really important, like, just be real with me, if that's something that you're doing. And so it's very important to have that conversation. Even the adults who are using chronically, now that, again, if you live where it's legal, I do ask my adults if they use it recreationally. I'll say, please don't, smoke before, at least 24 to 48 hours before you come in, if you can avoid it, for your actual session. Because if they are synthetically producing alpha brainwaves and I'm trying to uptrain alpha, I'm not going to get anywhere fast with that. So again, it's kind of a little bit of a struggle, but it's still important to have that conversation so they understand how these different substances can impact the brain. And in general, when you're talking about medications, I always say, I don't know how neurofeedback is going to impact your brain. We may see very quickly that you need to decrease your medications, but, and we may not be able to tell because, again, the medications are doing very synthetically what neurofeedback is trying to do organically. And so you may become very frustrated with neurofeedback because, you're taking an antidepressant, you're feeling good, and here's me, trying to, produce those alpha waves or get some beta flowing because you got too much theta, whatever it is. And your brain's already doing it because the neurotransmitters are already busy with the drug. So that can be very frustrating for people as well because neurofeedback will continue to progress and continue to progress. And they're like, well, it's not working. It's not working. So again, that's where we kind of have to have conversations and say, well, would you be willing to decrease your medication a little bit to see if to allow neurofeedback to work? Stimulants. Okay, so stimulants are one that I see quite a bit. A big portion of my population are children and teens with ADHD. So I see stimulants quite a bit. So these are drugs that increase the alertness of the user, causing increased attention, heightened energy, and elevated blood pressure. They essentially stimulate the user. It's exactly what it sounds like. They've been used in the treatment of asthma, obesity, various neurological disorders, and certain respiratory problems, but they are mainly used in the treatment of ADHD and narcolepsy. So it's also very important to ask if the person is narcoleptic and taking a stimulant for that. Okay, so common stimulants: caffeine, nicotine, cocaine, amphetamines, methamphetamines, and then prescription drugs like Adderall, Vyvanse. Those are all very common stimulants, but I mentioned the caffeine and the nicotine because it's also very important. If you're doing acute EEG, you want to ask them to abstain from caffeine and nicotine about 3 hours prior to the assessment, and caffeine about 8 hours prior to the assessment. Also, it's important to know, did they just smoke a cigarette before walking into before walking into the neurofeedback treatment, because that's going to impact, again, if their brain's already hopped up on the caffeine or the nicotine, they could be leaving a little bit more anxious if you're trying to produce beta waves. So very important to have that conversation and educate your patient on, please, if you could just wait, you can have a cigarette afterwards if you want it, or, whatever, just, try to abstain right before. So stimulant side effects: enhanced alertness, enhanced awareness, enhanced energy, staying awake for long periods of time, increased endurance, improved productivity, restlessness, increased motivation, increased arousal, rapid heart rate, high blood pressure, suppressed appetite, and growth suppression in children and teens. So again, stimulant side effects are important to pay attention to because stimulants have the same effect in most people, not everyone, but in most people. So it's really important that if you've got someone who's coming in and, they're on a stimulant because they've been diagnosed with ADHD, and you rung the cue and you go, I don't really see any evidence of ADHD here. And you say, but I do see a lot of anxiety. It's important to have that conversation and say, just because you responded to a stimulant does not mean that you have ADHD. So some common stimulants: methylphenidate, amphetamine, Adderall, Ritalin, Concerta, Focalin, Vyvanse. Again, these are just some that you may hear in your practice. So stimulants will increase beta and decrease theta, which is why they are prescribed for attention deficit, because at its core, ADHD is an overproduction of theta waves, which causes the brain to be very sluggish and tired. And so the person can't really turn on those beta waves to focus and be attentive, and they're attending to everything else in their environment except what they're supposed to be attending to. Sometimes the effect can be small and difficult to detect depending on the actual formulation of the stimulant. Again, if you smoke like half a cigarette before you come in, that may not disrupt neurofeedback. Ritalin and Concerta produce a decrease in delta and theta. You'll also see more posterior alpha increase and an increase in low beta. But these effects can be delayed up to 6 hours compared to amphetamines. Theta decrease may be secondary due to increasing alertness, and major effects on brain neurotransmitter activity, as I already said. You can even see some people who come in with depression, and they're, they say, well, I came in with depression, and they said I probably had ADHD, and they gave me a stimulant, and I feel a lot better. Well, that's because it's increasing beta waves, which is what depression is. It's a lack of beta waves. So cocaine and Ritalin are also actually taken up by the basal ganglia and enhance dopamine availability. So you can see a little bit more of that in that presentation. This is also presuming that your patients are honest with you about their illicit drug use, because that can also compound treatment as well. Okay. So just a few honorable mentions real quick before I move into the case presentation. If you have someone who's taking a thyroid medication, I cannot say it. That is important to document, because you'll see an increase in beta and a decrease in alpha. If you've got methanol, you're going to see EEG with marked slowing, which can actually be neurotoxic. Solvent, so if you've got someone who is huffing, the EEG shows slowing, alpha will become slower. If you have, for example, a woman who is doing hormone treatments, you can see increases in amplitudes in the high alpha band. So again, that can produce a little bit more of like focused, calm. That's kind of what that high alpha band does. Mercury, if you have any geriatric patients who had been exposed to mercury, or anybody who lives in an area where that might be. You'll see an increase of faster activity or higher concentrations in both fast and slow activity. Lead, so anybody who lives in a house where there might be lead paint, or anybody who might have been exposed to lead on the job. Outside of seeing the IQ drop, you'll see diffuse slowing in subacute exposure and then more with increased exposure. Okay, so my first case presentation is entitled The Zoned Out Zoroark, who is also a Pokemon. I'm going to be reviewing stimulants because, again, that's one of the most common medications that I've seen in my practice, and have very extensive experience with spotting someone who needs to have a discussion about their medications with their provider. So the Zoroark was a 12-year-old African-American male. Before neurofeedback, he was diagnosed with very classic ADHD symptoms: distractibility, difficulty focusing, and an inability to follow multi-step directions. He was very hyperactive, very disruptive in class. His teachers would get very frustrated with him. On the cue, he did show multiple areas of ADHD. So I saw it in the posterior, along the midline, and then also in the frontal lobes. So I was pretty certain that this was a clear case of ADHD. So we began neurofeedback treatment. I started with a 2-channel montage at C3, C4, and I did some training, which rewards beta and inhibits theta, which is exactly what, again, we want to do with an ADHD protocol. His parents reported he was increasingly calmer. His teachers noticed. I remember his teachers actually asked his parents, what are you doing? Because he's like a different kid. He was able to focus. His attention was better, decreased hyperactivity. He definitely was presenting as a different kid. So after about 10 sessions, his parents came in very concerned and said that the Zoroark was becoming, quote unquote, zoned out. They said he needed to be told directions multiple times. He was described by his parents as zombie-like, and they said that he would just sit there and sort of stare off into the distance and would really struggle. You know, they would have to say his name several times before he could kind of snap back in and you know, come to attention and finish his work. And so this is the point where I want to talk to you about stimulant over medication versus stimulant intoxication. So what the Zoroark was displaying is stimulant over medication. They present, again, very difficult to get their attention. They kind of just look very zoned out. I mean, they look over medicated. It's very obvious that they are, that something is not right, that their presentation is altered. Again, I describe them as zombies, versus stimulant intoxication, which is basically like, this is going to sound bad, but like seeing someone who is taking meth. They become very paranoid. They become agitated. They can, you know, show clenching of their jaw, you know, so they can have muscle twitches. They can become irritable, angry, overly anxious. And so that's a little bit more of a serious condition, and where you have to say, okay, it's time to go back like now and talk to your prescriber about, you know, either decreasing the medication or maybe pausing neurofeedback while we get the medication sorted out. Over medication is not as bad. It's just they're going to be a zombie like for a little while until you decrease the medication and, you know, get them to a point where they're, you know, at a good level for where their brain is. And so with the Zoroark, I told the parents, you know, I said, hey, he sounds very much like stimulant over medication, and I'm going to refer you back to your prescriber. Please have a conversation with them about decreasing his medication to see if they're willing to do it. And his prescriber was actually super excited about it, and they called in a new prescription. However, the pharmacy had just filled the higher dose prescription about 4 days or so prior to me making this recommendation, and insurance would not cover it. Would not cover the new prescription at the lower dose. And so it was that the parents were, you know, it was a capsule, so they couldn't break it in half or cut it or anything like that. And so they were super frustrated, but could not afford to pay for the medication out of pocket. And the prescriber said, oh, you know, he'll be fine. So for about a month, this person was on this higher dose of medication, and I sort of, you know, wrestled with, do I stop? Do we wait? The parents were super happy with his progress prior to it, but he sort of just kept getting worse, kept getting more zoned out, more having more difficulty with focus and attention, all of those things. And so we finally, I think the mom was able to get the prescription like a week and a half early, and they started him on that lower dose, and we started to see him sort of come back to life. And it was really cool for me because I was nervous the whole time. But when he started to be his old self again, we were all kind of like this collective sigh of relief. But that's also part of the ongoing conversation is, would you like to pause? You know, I said many times, I said, we can pause. And I was constantly monitoring for any stimulant intoxication or any worsening of symptoms outside of what they were reporting. And while he did get slightly worse, once we lowered the medication, he improved significantly within a few days. So, and then eventually, once we got to the end of neurofeedback treatment, he was off his medication completely. I haven't heard from them, so I'm hoping he's still off his medication. This was about a year ago. So that's kind of an example of a conversation that we should have with our patients regarding medications. So that is my first case presentation. And I know Judy said we would open for questions. So open for questions.
Okay, let's go to the question box. The questions that I have been fielding have been more administrative about speakers or something else. So let's see if we have any questions about case one. Here we go. It is my understanding that if the patient is taking benzos, the neurofeedback results are reduced. Please comment on your prior advice.
Yes. So any time you're taking medications or a patient is taking medications, the neurofeedback is going to be reduced. You won't be able to tell if it's a result of neurofeedback or if it's a result of the medication. And so it is important to be open to having that conversation about the person stopping or reducing their medications as neurofeedback treatment progresses. I'm sorry, I hope that answers your question. I think that's what it was asking.
Okay, great. Thank you. What is on your checklist that you mentioned earlier?
That's a good question.
Checklist of symptoms. That's what it is.
Yeah, I'll send it to Judy and Judy can send it out to you guys. It's not my checklist. It was John Anderson's checklist. And I really like it. So I use it and he gave me permission to use it.
Perfect.
But I check everything. So I check decrease in appetite, crying spells, increases in agitation, sadness, sleep, bowel movements. There's a spot for them to tell me if they've decreased or altered their medications. There's a spot for them to tell me if they are taking any herbs or supplements, because those can also alter brain waves as well. I'm trying to think of everything. I mean, there's about 35 different things that I ask on there in addition to ongoing conversations that I'm having with my patients. I take the check-in very seriously because that's how I monitor treatment just as overall. So I'll send it to Judy and Judy can send it out to you guys.
Absolutely. Thank you, ma'am. Next
Sure.
question. For case 1, was pausing medication a consideration instead of pausing neurofeedback?
Yes, it was. I do also discuss that. So for example, I'll say, hey, if I have someone who comes to me with neurofeedback and I say, what medications are you taking? And they say, oh, I'm taking a stimulant. A lot of children and teens will take medication holidays just so they can give their body a little bit of a break. And so I'll say, well, would you like to start in summer? If you take this medication holiday, that's the best time to start because then you're not in school. We can, spend several months looking at how neurofeedback actually is impacting your brain and hopefully send you back to school without any medications. But I talked to them and I said, what do you think with the prescriber? The prescriber was hesitant to pause medications just because they can go through a withdrawal. The parents had concerns because it was during the school year and they didn't want to see him backslide and with things like that. So we kind of collectively as a treatment team, decided that we were going to, he was coming to see me twice a week. So I said, I need you to be open and communicative with me. And so we decided with that case to just proceed as it was going.
Okay, great. Thank you. Here's another one. We understand that benzo increases beta activities. However, I thought benzos are supposed to calm people down. How come the beta got increased instead of decreased?
Yeah, so that's a great question. So increased alpha can actually also cause anxiety. So in the posterior region, if you've got someone who has persistent alpha and you try to go back there and uptrain alpha theta, you're going to make it worse. So sometimes increasing beta actually helps. Again, if they have a little bit more of like this theta, or they check out if they've got more of an inattentive type ADHD, then we're looking more at someone who, needs a little bit more of that like alpha increase. So, and sometimes again, increasing beta out of those, out of those red line areas can actually also be beneficial.
Great, thank you. We have another question. Could we discuss the possibility of using neurofeedback to mitigate benzodiazepine discontinuation syndrome and antidepressant withdrawal syndrome?
Sure. I mean, Here's the thing. Neurofeedback is not going to, if you're doing it under the right conditions with someone who is adequately trained to understand medications and, understands neurofeedback, you're going to see, very quickly a change. And so as long as you approach it with caution and you're just monitoring that, I don't see why not. Sure. I would love to explore neurofeedback and, and its applications for benzodiazepine withdrawal or in the management of chronic pain. Because that's how a lot of people get started with benzodiazepines. And, I think we can do a lot with mindfulness and neurofeedback treatment.
Okay, thank you. Let's see if we have anybody else.
If you do that, please email me and let me know how it goes. Because I would really like to know.
Perfect, thank you. Are these notes available to us online? You mean these questions and answers? No, but what I think would be good for you to have is the recording. And anybody here who paid for a seat at the live presentation can get a copy of the recording. I have to do a little bit of IT work. I won't get it done until probably Monday, but we'll make sure that everyone gets a copy of the recording, and that way you can hear the questions and hear the answers. I think that'll answer that question. Here's another one. How long to abstain from each nicotine and caffeine prior to neurofeedback training?
Well, typically we suggest 3 hours for nicotine and 8 hours for caffeine. That is not necessarily doable for a lot of people because, again, those are very addictive substances that are readily available and socially acceptable. So if they can't, you just, I always advise and I say, I hear you, I don't smoke, but, I do enjoy my caffeinated beverages. And so I say, if for some reason you cannot abstain from caffeine for that long, if you're going to go into withdrawals, don't suffer for neurofeedback. It's just on you as the provider to understand that, they, may not make as much progress because, again, their brain is already doing what we want it to do. And so that can be kind of, again, we just don't know what's working, but usually as the caffeine wears off, we'll start to see some of those changes. But yeah, I never say, please be completely uncaffeinated or no nicotine, because again, sometimes the withdrawal is almost more uncomfortable and can lead to treatment noncompliance. And I'd rather them come in for neurofeedback and make adjustments as needed on my end, as treatment progresses, than have them stop and go through withdrawals and just drop out completely.
How long was your treatment for this client?
40 sessions, twice a week.
Perfect.
That's standard.
Did you modify the protocol for patient one?
I don't think, no. No, my second case, I did modify the protocol. Oh, no, not for this person. I have a pretty good long-term recollection of my patients, but no, I did not modify the protocol for this one. So we were awarding 12 to 15 hertz when the brain was producing beta and inhibiting theta.
How do benzos reduce neurofeedback efficacy? Mechanism, please.
So again, when you've got these benzodiazepines that are increasing slow wave, we don't necessarily know if the benzos are creating the improvement or if the neurofeedback is creating the improvement. So for example, let's just take anxiety spectrum disorders, which are typically what most benzodiazepines are prescribed for. When we're doing that, we typically will train the posterior region either at O1, O2, or at P3, P4 to have, to do that eyes closed, because when the eyes are closed, alpha naturally increases and there's more opportunities for the brain to be, to get that feedback and to get the positive feedback from the actual equipment. So if you've got a benzodiazepine already in someone's system, whether it's a PRN or a long acting, the brain is already producing a ton of alpha. So it's unlikely that they're going to get rewarded. And so those neurons don't know when to make the connection, which again gets into like the feedback portion of it. And they're just, I mean, they may fall asleep. Again, medication is a Band-Aid. That's how I describe it. Medication is a Band-Aid, whereas neurofeedback is the surgery. So neurofeedback is trying to get those neurons to, wire together and fire together, increase synchrony, increase coherence in different areas of the brain so that the brain functions better. Right? So if you've already got the Band-Aid on the wound, we can't get to it with the surgery because the brain is already doing what we want it to do. So they're not going to get as much feedback as they would if they came in with a quote unquote raw brain. So it's just, it's not necessarily that the brain won't change. It's just going to change much slower. And the person may get a little bit more agitated. They may think that neurofeedback isn't working. They may not be able to identify changes. And that's where it can become very frustrating as a provider because we know neurofeedback works. It's just these other mitigating factors, which don't just stop at medication. There's environmental factors as well that impact our treatment.
Okay, I don't know how you have your schedule planned. Do you think we need to move to case 2? Because we still have some more questions, which I can copy and send you, and then we can email the questions and answers to everybody. What do you think?
Sure, and I can stay after too if people have more questions, so that's totally fine.
So would you rather do the questions now for case 1, or do you want to move to case 2?
That's fine. We can do the questions for case 1.
Okay, perfect. Thank you so much.
Sure.
Let's see. When you said you can see marijuana in the brain map, what did you mean?
High alpha. High persistent alpha at C3, C4. Sometimes at P3, P4, you'll see persistent alpha. But lots of alpha. Lots and lots of alpha.
Okay, thank you. In case 1, did the QEEG show high beta and low theta? If so, neurofeedback training would be based on symptoms and not the QEEG results. What did the final Q show?
No. So if you flip that, so the QEEG showed high theta and low beta, which is the ADHD presentation, and that's what is being rewarded is 12 to 15 hertz beta. And the final QEEG presentation showed a normal presentation of theta, normal presentation of beta. I can't remember exactly what it showed, but I do remember we decreased his medication and he didn't need stimulant medications after we completed neurofeedback treatment.
Thank you. Here's another question. Could you clarify paradoxical beta increase via beta spindles on benzodiazepines? Also, could you comment on cases in which individuals are on multiple medications?
Oh my gosh. Okay, so beta spindles are just tight bursts of beta that can be seen on the QEEG, which they can, be in abundance of 12 to 20 hertz. Sometimes if you get those beta spindles, they can also be in the, the beta 2 range, which is, 22 hertz and up, which we typically associate with panic attacks. And so you'd have to look at the raw QEEG tracings to see if you've got any, like beta spindling or things like that. So, and multiple medications, that is a tough one because again, it sort of just goes back to this underlying sort of theme that the more medications you have, the harder neurofeedback is going to have to work because again, you never know what to adjust. You never know, okay, if this person is on an antidepressant plus a mood stabilizer or if or an antipsychotic for treatment-resistant major depression, what do you adjust? Do you adjust the antipsychotic? Do you adjust the antidepressant? And that's where I think it's important to have an open conversation with the prescriber to see what their thoughts are. Usually I recommend sort of starting with the heavily sedating ones like the antipsychotics and decreasing those a little bit to see if their depression isn't better managed with just an antidepressant. But yeah, multiple medications is a rough one, and it can get very, very murky. I mean, I've treated people with seizure disorders who are on multiple medications to control their seizures, and it is a very, very slow climb to getting to a full 30-minute session of neurofeedback, because I want to make sure that I am assessing how their treatment is progressing. I'm communicating regularly with their neurologist to make sure that, they're checking in. So I'm, usually sending progress reports at least once a month, if not more, to their neurologist, making sure that we're in regular communication, and they understand, and the neurologist supports neurofeedback. So I also will not proceed if I've got another provider that is like, I don't know how this is going to impact their medication or their disorder. So multiple medications make it very, very complicated. And if you are a new neurofeedback provider, I would probably pass that on to a little bit more of a seasoned neurofeedback provider so they can monitor that a little bit better. But remember, it's not going to impact them that first session. They're not going to have one session of neurofeedback and all of a sudden everything's haywire. It's going to be a slow progression over a few sessions, and you'll start to see these, they're doing okay, or they're not seeing any changes, and then all of a sudden things kind of start going haywire, or start, seeing these weird side effects or whatever. And then you kind of go, okay, I think we need something else is confounding the picture. We need to address something else, whether it's behavioral interventions and they need a therapy referral, or it's time to go back to the provider.
Great, thank you. Another question: what are some examples of herbs or supplements that can impact brain activity?
Echinacea, ginkgo biloba. I'm sorry, not ginkgo biloba. There was one that was, and I'm blanking on the name. I don't think it's necessarily prescribed or given anymore, because it was used for weight loss, and it actually, ate away at the fatty tissue around the heart, and so it was causing massive problems. And I'm totally blanking on the name. But if you're taking your regular vitamin B, I'm fine with that. I just usually will ask, does it have any caffeine? Is it, does it have any weird herbs that I've never heard of? Does it come from overseas, or because vitamins and herbs are a very unregulated industry just to begin with. And there is little data that supports taking them outside of their natural presentation. For example, vitamin C may interact with other properties of the orange. So when you take the vitamin C out of the orange and just try to take it as a pill, it may not be as effective at quote unquote boosting the immune system as it is if you just eat the orange. So there is, so it's those kind of things. I just will have a conversation with them around, are you taking any vitamins or herbs or supplements, mostly caffeine, because herbal tea has caffeine in it. Some daily vitamins will have a little bit of caffeine, again, for stimulant purposes.
Great, thank you. Did you say standard treatment for neurofeedback for ADHD is 40 sessions, or do you mean standard in general?
Standard in general. Yeah, 40 sessions twice a week.
Did you inform the patient of this at onset of treatment?
The 40 sessions?
No, I don't know. Oh, yes. Yeah, that is referring to.
Yes. Mm-hmm. Oh, yeah. Mm-hmm. Yep. I have a very detailed informed consent. And it spells it out very clearly that typically 20 to 40 sessions, most commonly 40 sessions, are required in order to, first of all, 7 to 10 sessions, and we start looking at permanency. The research suggests that you overtrain. So once you've achieved that 7 to 10 sessions and we're looking at permanency, the research suggests that you overtrain to make sure that those new connections are very solid. I do a cue to start off with, I do a cue midway, and then I say, at that point, I may say, not really much left to do, see you later. So that's not necessarily, I don't force everybody to go to 20 sessions just because that's what the research says. It's done based on an individual case basis. But yeah, so usually about 20 sessions, we might adjust the protocol a little bit, or we might move to a different site where there's still causing some that's still like a problem site or whatever, or, change the protocol, change the placements, change the montage, things like that. So 20 sessions is usually, I call like my cleanup. So we're just either overtraining some areas. 40 sessions also allows for vacations and illnesses and missed sessions and, weather, because I'm in Illinois and that's a thing here. So it kind of builds all of that in.
Perfect. Let's just take one more, and we better get to client too, I think. But we'll
Okay.
keep all these questions, and I'll send them to you on an email. I already started an email to you, so.
Okay.
Okay, here's the last one. I've read marijuana affects the brain waves for 3 days. If you have a client who used marijuana on the weekends, would you see the EEG effects wearing off? And if so, how would you keep feedback rewards consistent, and how would you track progress? So
that's a great question. Marijuana, that one is going to be the bane of my existence. So it's just rough because now it's legalized and recreational, but I mean, I totally understand that it has, these pain relieving properties, and I see applications and uses for it, but it does have a very profound impact on the brain. And so it can, yes, 3 days, sure. 72 hours, absolutely. It can stay in the body, or, impact those brain waves. And that's a conversation that, you have to have with your patients, because we're talking very much, it is going to impact neurofeedback, and it kind of speaks to, you're willing to comply with treatment. But sometimes it'll show up and sometimes it won't. So let me just put it that way. It'll show up on the QEEG as, again, sustained alpha production. And that's when you can say, hey, did you recently smoke marijuana recently? And they can either lie to you, which people do, or they can say, yes, I did. I smoked it 3 days ago. Wow, I thought it would be out of my system. I've had both of those happen. And then, when that happens, then it's important to have a conversation around what marijuana does to the brain and how it impacts neurofeedback treatment. And you won't be able to tell if the person's anxiety is getting better, or if it's just the marijuana still present that's increasing alpha synthetically. So yes, you can see it on a QEEG to sort of like long and short answer your question.
Okay, great. Thank you so much. That was, sure. I love when we have great questions. I think it makes me feel like we're really getting somewhere for everybody.
Yeah.
So I'm going to go ahead and mute me again, and then you can present case 2.
Okay.
Thank you. Thank you.
Sure. All right. So case 2 is the sleepy salazole. The medication that I am reviewing in this case to present is case presentation is antidepressants. I had a 17-year-old Caucasian transsexual female, pre-neurofeedback treatment. She presented with anxiety spectrum disorder. She had a history of bullying and harassment due to being transsexual. Expressed panic attacks, including shortness of breath, avoidance behaviors, racing thoughts. She also had isolation from family members because she was, trying to push to get her birth certificate changed to female, from male to female, and her parents sort of thought this was a phase she was going through, and so she was very upset that they weren't sort of taking it seriously. So I think, again, that was an environmental factor. I'm also going to place a caveat on this, that this case was very early on in my neurofeedback career, and I don't think I was very good at, not really understanding. I didn't have a master's degree in psychopharmacology. I didn't, really understand how medication was impacting neurofeedback. I wanted to talk about this case because I feel like that's where a lot of people start or are currently. And just to let you know, we all started somewhere, and that's totally okay. We all, are learning together as this field grows. So throughout neurofeedback treatment, I did a variety of, trainings with her. I did a 2-channel sum training, C3, C4, rewarding beta and inhibiting theta. And then I moved to alpha theta at 01, and then eventually at P3, P4 to address the anxiety symptoms. Initially, she was reporting decreased racing thoughts. She became more open to being with family and friends, eliminated her panic attacks. After about 20 sessions, Salazzle became super duper sleepy. So her parents said that she would fall asleep in class. She couldn't stay awake at home to complete her homework. She would actually fall asleep on the way home from neurofeedback treatment, which could be a combination of just the brain training itself, but then also the antidepressant. And if you remember, I did mention that with antidepressants, usually what I see is this increased tiredness. Everything will be going fine, and then I'll start hearing reports of, gosh, I'm so tired, I need to take multiple naps a day, which I never really used to do. And then it's time to have a conversation with the parents about decreasing the antidepressant to sort of manage all of that tiredness. And that's exactly what they did. So they went back to their provider. Thankfully, the provider was very open and also was willing to decrease the medication. And we started to see a decrease in the sleepiness, more alertness, still had all these other great, no panic attacks, decreased the racing thoughts. Salazzle was being really great with her family and her friends and not isolating as much, having more productive conversations with her family surrounding being transsexual. And so that really, really helped. And so they ended up dropping out prematurely from neurofeedback due to my schedule and the Salazzle schedule. So I don't actually know what became of that case. Which, that happens, but they couldn't accommodate what the openings that I had. So I haven't heard from them either. So that's where we left it, though, was, decrease in medications and the antidepressant, and then also an improvement in anxiety symptoms. Okay. So the key to every relationship is communication. So I really want to stress early communication with your patient. So here's the part where we talk about how do we have these conversations. So you want to track symptoms at every appointment. Very, very, very important. Whether they write them down or I'm having a conversation with them, I want to know what's changed, what's gotten worse, what's gotten better, what stayed the same. A very big clue for you is going to be if the patient begins reporting unusual symptoms. And so with the Salazzle case, what happened was, so they, I think there were like 4 or 5 treatments where she would come, I'm just so tired. I'm so tired. I mean, she'd be yawning in session, and it kind of clicked for me. And I went back to her chart and I was like, oh, she's taking an antidepressant. I Googled it, and one of the side effects was increased drowsiness. And so that sort of alerted me to say, hey, go back and check with your provider. So now I do that way earlier on when someone starts reporting these things, that are getting worse. Now, mind you, it's not uncommon for the EEG dynamics to destabilize a little bit in the very beginning of neurofeedback treatment. So that's not the same as like these weird side effects. So basically, if we're looking at the operant conditioning principle, we're looking at the, things as soon as we introduce something new into a closed feedback loop, the system kind of goes, wait a minute, what is this? I don't like it. Things get a little bit worse. And then eventually, as we progress with treatment, it comes back down again. So after we've seen that, if we see that spike, and things kind of stabilize and start to improve, then if someone comes in with these unusual symptoms, just do a quick Google search and check, like WebMD, or just to see what common side effects, or you can even go to the manufacturer website if you want a little bit more, solid referral or information. Check the side effects and just see if it pulls up. And if that's the case, just make the suggestion. It's on the patient to actually take your suggestion. I always ask for the name of the medication provider, and I send a letter introducing myself and briefly talk about how neurofeedback impacts medications as the brainwaves stabilize. It's standard letter that I send to anybody who's prescribing. It alerts them to me. It's a great marketing tool, but it also, just alerts the physician or, that or nurse practitioner or, who's prescribing the medication, that the patient, is engaging in this new treatment. And it's very important that they understand that, we have to, and most preferably, be receptive to altering medications, which comes up to my next slide. I also provide regular updates, at least on a monthly basis, to the prescriber, and I'll just send a quick progress note saying, patient treatment remains steady, no adverse side effects reported, thanks, kind of thing. So you're gonna have a mixed bag of people who are not receptive to neurofeedback. Either they haven't heard of it, and that makes them nervous, or they are very protective over, things like malpractice insurance, because when you're getting into these harder cases and titrating a person down, unless you're Steven Stahl, it's, a lot of providers are very hesitant to decrease medication because it can create, tolerance or resistance. Even if you try to put them back up on the same medications. It's not like you can, in some cases, for example, major depression, if you stop or alter a course of antidepressants and antipsychotics, you can't just restart it and it may not have the same effect. So there is that to be that to be sort of reckoned with, and you could also have a bad protocol. So, it could be on you that, you have to be reviewing the protocol to make sure that you are training the right areas, you're not overtraining or overstimulating or producing, more beta waves and seeing this anxiety. So another option, if you have a provider who isn't receptive, is to change the protocol and see if that doesn't take care of some of those side effects. Again, if it's the medication interference, the only thing is to really try to decrease the medication and see what happens. I have a very early conversation with my patients. Again, I have a very long informed consent. And the informed consent has a specific, section about medications that says, you must be willing and, to discuss medications not only with me, but also with your provider, should the time come when, we are seeing that, you might need a decrease in your medications. And again, if the prescriber is unwilling to adjust medications, review if neurofeedback really is the best treatment of choice. You can always switch the protocol if the person would like to continue. But I always, talk about the patient advocating for their needs and saying, if one of the goals that they come to me with is decreasing their medications, then I would hope that they're ready to have that conversation with the provider. And if their provider gives pushback, to sort of advocate that, for themselves in a very healthy manner to, decrease medications at the time. And most of my patients are very receptive to that. So it's not usually a problem. It's usually the provider who gives me a little bit more pushback. I have many providers who know me and who have had patients who have they've either referred to me or have sort of stumbled upon me just because they, really wanted, another treatment option, having tried a bunch of treatment options. And so they know who I am as a provider. They know my background. They know my work. And so they are more than willing to engage in a conversation with me and to talk about, decreasing medication medications. And so that goes a long way. And that's, again, why I recommend these monthly progress notes, because it keeps you on their radar and it keeps you in front of them, you know, as a provider and as someone who truly cares about the progress of your mutual patient. So for me, that's very important. Okay, air handshakes all around because Corona. So that's it. Thank you so much.
Thank you so much. So we do have some more questions.
Okay, great.
Remember when we were talking about the herbs and supplements? So 2 people sent in, was it St. John's wort? And the other person said, was it fen-phen that you were thinking about?
Fen-phen. That's the one. I knew it began, I was like, P, I could see a P in my head, but yeah, it was like a fen-phen. St. John's worts does have interactions with some psychotropic medications. So you do have to be, it is, you know, one that is out there that you have to be aware of as well. So thank you for whoever brought up St. John's wort, because that one does have interactions. So it is very important to track that use of that one as well.
Perfect, thank you. When you have this extreme drowsiness, do you change the hertz range or just plow through it?
Good question. So that depends. If I suspect that the extreme drowsiness is related to it's just something in the neurofeedback treatment, yes, I will go back to the Q and I'll look at, you know, right brain versus left brain, or C3, C4, P3, whatever, and make adjustments based on what their Q said. If I suspect it's due to medications, and, you know, sometimes I even will I'll change the protocol, just, you know, maybe increase the left side, which is where depression lives, or decrease, you know, the right side, or try and maybe even increase the right side a little bit, you know, to speed up some of those fast waves. But if I really do, and if none of that works, then I really kind of every session I'm pushing them to just ask. That's all I say. Please just ask your provider. Ask them about side effects. Ask them about, you know, your medication. And again, the providers who are open to it and sort of are on the cutting edge and understand neurofeedback, or who I have a relationship with, they're more than willing to make adjustments. It's the ones who are kind of incredulous that neurofeedback actually works. And, you know, you can't give someone feedback on their brain and actually change it to the point where they no longer need medications. That's not a thing. And that's when they come back to me and they say this, and I'll say, well, actually, here's some research, you know, feel free to send them to my website. Here are some research articles that actually prove the Corydon Hammond article, Neurofeedback, What is Neurofeedback? An Update, is a great meta-analysis to give. I give it to all my patients. And, you know, I'll say, please take this back. And if they're willing, you know, again, just continue to advocate for yourself, you know, and then I kind of see if they're willing to. If they're not, then I change the protocol. Maybe we work on something else. You know, very rarely do I have a provider, after I've sort of given them research, advocated for the change, even if I don't know them. Very rarely do I have a provider who is unwilling to make even a tiny little adjustment. Usually they're willing to make a tiny little adjustment. And I know that if I can get them there, and that's really what was in the picture that was, you know, confounding this, and that, you know, patient doesn't become suicidal or, you know, backslide into their, you know, major depression, then they're a little bit more willing to make a little bit more of a tweak. So it's a progress, but or a progression, and it happens.
Okay, great. Thank you. We have another question. Do you think neurofeedback can be an effective treatment for someone experiencing trauma? Are there side effects to neurofeedback treatment like there is for medications?
Yes, there is. Great question. So, yes, trauma can be treated with neurofeedback, and there are 2 places you could do alpha theta training at P3, P4. Or you could do my favorite, which is alpha theta training at FPO2, which is sort of right in the eye socket of the right orbital bone. I'm pointing to it on myself, but of course you can't see me, so I'm sure nobody has any idea where I'm pointing, but it's in the orbital bone, kind of right next to the inion, for those of you who understand the 1020 system, on the right side in that right orbital bone, like right underneath the eyebrow. So you can actually do one monopolar placement, put an active electrode there and train just a normal alpha theta training. And that actually hits right back to the amygdala, which is a lower brain structure that we often can't, get to with just surface level electrodes. And so by putting the electrode there, that kind of hits back to that amygdala and turns down the fight or flight response. So that's a great place to start. Are there side effects to neurofeedback? Absolutely. The most common ones I see are improved sleep. So that's a good one. Headaches, that's one that I see pretty common. And then agitation or irritability. I don't see that one as much. But yeah, so neurofeedback itself, if you've got someone who's not taking medication, does have side effects, which, I don't know if anybody's taken the 36-hour didactic course, like I have one, and we go over potential side effects from neurofeedback treatment in my course. So it's, yes, there are side effects to neurofeedback. And that's why I say, for example, if you got someone who already has persistent alpha and you're trying to, you're increasing alpha where they already have too much alpha, it can cause issues. They can become more foggy, irritable, anxious, agitated. So you have to sort of be monitoring your protocol. That's why I say monitor every session.
Great, thank you. We have another question here. How do you help a patient on 40 years of, I don't know that I can pronounce this, levothyroxine, which is a thyroid med, and has anxiety and high beta?
Alpha theta. You could do alpha theta in the posterior region. Levothyroxine, thank you for pronouncing that amazingly, Judy. I couldn't even pronounce it. It was one of my honorable mentions, but I was like, I don't know. So levothyroxine, obviously they can't stop that because that is for a medical condition and that medication needs to be continued. And that's where you have to decide, is the anxiety a product of the medication that can't be stopped? And can you, just do some neurofeedback to, improve mood, maybe decrease anxiety, along with maybe some deep breathing. So I never say that neurofeedback should be a standalone treatment. I definitely, believe in treating the whole person. So I am often, providing behavioral interventions, track your thoughts, or please go see a therapist if you're not already seeing one. To make sure that they're also doing these other things to understand why they had the symptoms in the first place. So in that case, it's going to be tricky because you'll have to sort of monitor. But alpha theta, I would do it either at P3, P4 or at O1. So a bipolar montage at P3, P4 or O1 with a monopolar placement. That would be my recommendation.
Great, thank you. This is unusual. We got the same question, two different people back to back, so it must be an important one. I love it. Could we get a template of the letter you send to the prescriber stating how neurofeedback can impact medications?
Sure.
Okay, now I'm going to build a web page to house a copy of the recording and the handouts and everything else, and that's where I'll put it. So you won't hear from me. My attendees is who I'm talking to. You're not going to hear from me. It's going to take a little bit of time. I can't probably get this done. We have to give Dr. Conway time to go home and have a weekend. So we'll get this all sorted out for you. But I think it's a great thing to post on there.
Yeah, for sure.
All righty. Do you conduct a neuropsych assessment before QEEG? If so, what are the major domains you look at pre and post neurofeedback treatment?
No. I only do a neuropsych assessment if I feel like I need more information. That's the wonderful thing about QEEG. You can get a ton of information in a very short period of time. And I love that. And I'm all about working efficiently. So for neurofeedback treatment, I do the QEEG the first time, every time, almost every time, because I have had kids who are very hyperactive, very inattentive, cannot sit still, and I get a ton of movement artifact, and I just cannot complete the intake, and then or the QEEG, because it's just totally skewed. Very rare that happens. And then I just proceed with, okay, I guarantee we're looking at an ADHD presentation. But neuropsych, no, most of the time people come in, they do the Q, they start neurofeedback, and then if there's other things like, poor school performance or things aren't improving the way I want them to, I may do another Q, or then I may refer for a neuropsych assessment and have that completed. So, but no, I don't make that a part of, insurance gets really tricky with psych testing. It has to be medically necessary, which, a lot of times it is, or we can, make it sound like it is. And so, no, I rely very much on QEEG data.
Okay, thank you. Next question. Do you conduct neurofeedback if a patient has a structural problem? For example, a small benign cyst in arachnoid area that is deemed benign?
Yes. Yeah. So even if you, and that it's arachnoid, Judy. I know. Darn Greeks.
I know.
Yeah. So
thank you.
You're welcome. So yes, I do. So here's the thing. I have been practicing neurofeedback, and I am very confident in my neurofeedback skills. I have the 36-hour didactic course that I lead at least once a year, if not more, if there's a demand. Like I said, I do consultation services. So, if someone says, I really want, the 36-hour course, but I don't want to pay for all 5 of my clinicians, they can pay me and I'll come and teach it to them. So I've led this course quite a bit of times, and I do have a really good understanding outside of literally almost practicing neurofeedback day in and day out for the past 5 years. I would feel comfortable taking on a case like that. I'm more looking at when there are structural changes, the ones that you have to be very concerned about are autism, intellectual disability, or a seizure disorder or a stroke disorder. So autism and intellectual disability obviously cause, structural changes, abnormal development, and I will have a conversation. Again, I'll talk to anybody. I love to talk, obviously. So I'll talk to the parents, I'll talk to the caregivers, and I'll say, listen, we're obviously looking at someone who's got an autistic, disorder, and there's obviously some abnormal brain development. In general, even if there was normal brain development, I still cannot tell you how your individual brain is going to respond to neurofeedback treatment, right? So when we've got abnormal brain development, I'll say it 2 times. I'll say, now I really can't tell you how your brain is going to respond to treatment. It is also very likely that because there is this abnormal brain development, treatment is going to be extended. Because we just are not going to know how the brain develops. We might have to change protocols a bunch of times. And so we have to sort of, be open to the fact that it may go beyond that 40 sessions, when we're looking at that kind of presentation. But a benign, subarachnoid tumor, no. Unless the thalamus is impacted, then and then I would ask the neurologist to say, is the tumor, impacting, because, cortical generation of the brainwaves typically is mostly related to the thalamus. So that could, but I've actually had someone who's come in and said, well, I have a very small thalamus. And I was like, okay, let's give it a shot. And it was fine.
Interesting.
Yeah.
All right. Next question. Can you speak a little more about hormones and how that can affect or impact neurofeedback? Would someone having imbalanced hormones impact brainwaves and neurofeedback treatment?
Yes, because it is going to kickstart those slow waves. So I have not, because again, I trend towards the younger part of the lifespan. I don't typically get a lot of the adults. Sometimes I get the parents who bring the adults or parents who bring the kids and say, "Wow, my kids are so different. I want to do it," and then we get that. But again, if someone is on hormone treatment, it's some of these things they can stop or alter. Some of these things they cannot. So the level thyroxine, that's a great example. That is not something that you can stop. And so it's just on you as a provider to understand how that medication impacts the brain by inducing those, faster brain waves, so that you can understand how that's going to impact neurofeedback. So because they're continually taking this medication or if we go back to the hormones, that are producing these very slow waves. If you're trying to, treat an attentional disorder, for example, and you're trying to get, kickstart those beta waves, it may be an uphill battle for you. It may be slow, and it, maybe kind of like the tortoise and the hare, where slow and steady wins the race. So it's just, again, something for you to be mindful about, that, if they're on that this is likely what's happening in their brain. Alternatively, if they're taking hormones and they've got anxiety, and again, we're seeing this very, theta, whether it's high or low theta production, now we're talking about increasing theta, which could make them more sleepy, even though there's normal routes, normal bandwidths, for example, like 12 to 15 hertz, or 7 to 12 for alpha. If we're trying to increase that, now it could just make them a little bit more tired. And it's just, again, something to monitor. Maybe you want to train, maybe you want to adjust the frequencies so you're up towards the higher end of the alpha, so you're not increasing that slow alpha or early theta even, to make them more tired.
You have been so generous so far. I still have more questions in the queue.
Okay.
Can you take a
Cool.
few more?
Yeah.
Oh, you're the best. Thank you.
You're welcome.
Do you recommend neurobiofeedback at the same time with therapy?
Yes. Oh, yes. You are gonna, oh my gosh, that is like, for me, that is like winning the Triwizard Tournament, if anybody is a Harry Potter fan, because oh my goodness, I cannot tell you when I have someone who comes to me who's just taking medication and just doing neurofeedback, yes, are they gonna make improvements? Absolutely. But when you get someone who is doing therapy in conjunction, it's like the Trinity. We're looking at, for me, that is where the magic happens, because neurofeedback can decrease that mental rigidity and that, unwillingness to sort of engage in treatment. And that is, when it does lower that and increase, it opens them up more to the therapeutic experience. It's, it's like now we're getting somewhere, because now they're gonna, again, neurofeedback is exactly what it sounds like. You come in, you talk about any kind of increases, decreases in symptoms, and then you're training for 30 minutes, and maybe, you shouldn't be talking when they're training. And then it's like you clean them up. How do you feel? Check in with them, make sure they're not dizzy, say, hey, have a snack, and then see you later. 45 minutes, right? There's no discussion as to why did you have the symptoms in the first place? That's where therapy comes in. And that's where therapy is very important. So, I always say, hey, if you can get yourself, I actually also have that in my informed consent, that you need to be willing, if I think that, there is something going on in your environment that is not helped by neurofeedback, you need to be willing to, reach out to a therapist and start to discuss some of these maladaptive relationship patterns or cognitive distortions, because neurofeedback in and of itself is not going to improve. Medication in and of itself only has a 1% to 3% improvement in overall presentation. It's not a lot, so yes, absolutely. Again, long, short answer.
Thank you.
Uh-huh.
Can you send us the link to the article you just mentioned?
The Corydon Hammond?
I don't know. I don't. That's the only article that I heard you say, but I was doing some other things.
You can also Google it. If you just Google what is neurofeedback and update, it'll pop up. It's like the first one.
Not to mention, I bet it's posted on the ISNR webpage.
Oh, absolutely.
Yeah.
I'm sure it is. Yeah, for sure. That's a great one. Very easy to read, a great meta-analysis on almost all of the conditions that there is some research into how tinnitus, migraines, so even non-mental health. So that's a good one. I like that one. So yeah, if you literally just Google what is neurofeedback and update, it'll pop up.
Okay, perfect. Thank you. If that's not the article you were talking about, please email me.
Yeah.
All right. Can you send us or reference some articles and research that shows the impact of benzos on the brain? Psychiatrists and family docs are still prescribing them so frequently.
Mm-hmm. I'm trying to think. I don't think I have those specifically. I do recommend, if you are going to add neurofeedback, you should have research on your website. I don't necessarily do it for specific medications. I do it for conditions. So my website is right there. You can all see it. It's cerebrumil.com. You can see how I set up my website. Please don't steal my copy. If you want it, you have to let me know, because I do talk about neurofeedback in a very relatable manner, and how it presents in the brain. So just a caveat with that. I did a lot of research on that and wrote it myself. So I don't talk about medications in general, but I'm sure there is research out there that describes how it is. So I don't have that on my person, if that's what you're asking.
Okay. Next question. FPO2 has a time issue. Seaburn-Fisher's trauma protocol, it might only need a few minutes.
Yeah, so thank you for bringing up. I love Seaburn-Fisher's book. That's kind of where we get it. And I think it really goes based on like tolerability. So, I guess I don't have any issues necessarily with doing it for a prolonged period of time. But yes, I guess. I don't know if that was a question.
Can you also post some of these neurofeedback placements you have mentioned for trauma?
It's in the handout. I think I put, oh no, did I put it in there? Yeah, I mean, it's P3, P4, alpha theta training. Oh, sorry. The person also did ask about side effects. And yes, there can be side effects in that when you uptrain alpha theta, you can unlock trauma. And so it's very important to be checking in with your client and seeing how they're doing. They can start to have very vivid dreams. That's happened to me. I've also had a client when I was doing P3, P4 alpha theta training with her eyes closed. She just kind of sat up and said, Dr. Conway, I'm getting very anxious. And she started to have kind of a panic attack, and some of the trauma that she had previously sort of came in, and I stopped immediately, and I sat and I processed with her. We did some deep breathing, and she was safe to like leave the office, and that was it. But yeah, so sorry, I don't think I finished the answer to that initial question. But yeah, so if you want to just write it down, I don't know necessarily how to post it. It's just P3, P4 in the posterior. If you follow the 10-20 model using alpha theta, or O1, a monopolar placement at O1, or FPO2 if you do the Seaburn-Fisher.
Okay, great. Thank you. What is your success rate with addictions? For example, sex addictions, internet addictions?
Ooh, so, Well, I'll admit I've never treated that with neurofeedback. I have treated other addictions. And I'm of course once again blanking on the penicillin and Kukulski protocol, which is alpha theta at 01 combined with a bunch of other stuff. But alpha theta does have research that if you do it very consecutively, it can reduce alcohol cravings. It can reduce the feelings of intoxication that you get from alcohol. I've never tried it with a sex addiction. I would put that up there on the impulse control disorders category. So I might treat it like like an ADHD or like an OCD, and maybe try to uptrain some alpha theta in the posterior region, or even try to do some training to just exercise more control. One of the things with neurofeedback is that sometimes if they've got a lot of slow wave and you increase that fast wave, so you improve their ability to make decisions, doesn't necessarily mean you're going to improve their ability to make good decisions. So I always tell my parents, please, I'm sorry, if your kid is, paying attention in school, but, breaking into your safe and looking at porn in the afternoon. I've had that happen.
Oh my.
Yeah. I've had that happen.
A guy I know, Richard Davis, he's BCIA certified in neurofeedback. He's out of Texas. He has done a lot of work with sex addictions, and that's just something randomly that I know.
Wow, cool.
Yeah. So if I email me with this, and then I can write back and give you contact information for him, or you can look him up on bcia.org and go into the Find a Practitioner, and in the practitioner, in the last name, the provider box, just type the name Davis, R. You're going to see 2 Richard Davises at least, but the one I'm talking about is in Texas. Okay. All righty. Let's see. Would you be willing to share these pointers in the consent form of yours that revolves around psychotherapy?
I don't understand the question. The pointers?
When you have a consent form, maybe that's what they want to see, is a copy of your consent form. Would you be willing to share that?
Sure.
Okay, perfect.
So the consent form?
Mm-hmm. We can put that, again, we can put that on that webpage as soon as I get it built. All righty.
Yep, I'll email it to Judy.
Effect of PRASOZIN on neurofeedback. Question.
I'm sorry, I didn't even.
Prazosin, PRASOZIN. Effect of prazosin on neurofeedback. Prazosin is used off-label for PTSD nightmares.
I don't know. It's a good question. Urinary retention medication and an antihypertensive. Oh, it's an alpha-1 blocker. Okay. Okay, so if it's going to treat high blood pressure, I would wager a guess that it's going to decrease, I don't know, I would guess, high blood pressure is typically associated with a faster rhythm within the body. So if we're looking at the oscillations within the body, I would assume that it would increase like those alpha waves. So if you're doing an alpha theta protocol, you might also be looking at, increasing more alpha and making them more relaxed, more sleepy, potentially a little bit more anxious. Because again, if you've got a lot of anxiety, sometimes that can cause some irritability, or a lot of alpha, sometimes that can cause a little bit of irritability. That's a guess, though. I'm not familiar with the medication. A guess.
It's interesting that we've been talking a lot about alpha theta, and BCIA hasn't done an alpha theta webinar for a couple of years. And I think actually the same Richard Davis I was talking about for sex addictions, I think he and his wife, Jeannie Davis, who many of you may know, Jeannie was neurofeedback instructor and ran a neurofeedback lab at University of Texas, Arlington, I want to say. University of Texas somewhere, I can't remember. Anyway, you probably know her name a little bit, maybe more than hers. But maybe what we need to do is bring back an alpha theta webinar.
Yeah.
So I'll have to look into that. Got a few more holes.
Alpha theta. It's a great one.
Well, we'll have to look around for that then. All
Yeah.
right. Well, we got through all the questions, and you stayed so long. You were so generous with your time. And as always, it's always so fun. And I love when people have lots of questions because it means that you're hitting them where they live and hitting them where they, and that's, to me, that's what says a successful webinar. Thank you all for your attendance. And I hope you all have a wonderful day and a wonderful weekend. And to all the moms out there, happy Mother's Day to you. So I think now we will end the webinar. We will let Dr. Conway go get a glass of water and put her feet up for a minute. You worked hard, girl.
Well, thank you.
Thank you so much. And again, everybody, you'll be receiving your email with the eval and the exam, but not till next week. I have a lot to do between now and then. So take care, everybody. Have a wonderful weekend. Bye-bye.
Thank you, Judy. Bye.
Talk to you soon.
Yeah, bye.